Okay, we are live. So, team, let's talk about fractures of the clavicle and scapula. So we'll go over anatomy review. Clavicle is pretty straightforward, but the scapula is a pretty unique bone. So we'll talk about it, all of the anatomy of the scapula. We'll start with clavicle fractures and then work our way over to less common scapula fractures. So starting with our bony anatomy, the clavicle is a relatively simple but kind of funky bone in that it gets flatter towards the end, so that sternal attachment and the acromial attachment, and it becomes more tubular in the middle or body or central third of the clavicle. Remember, it's articulating medially with the sternum at the sternoclavicular joint and laterally with the acromion, making the acromioclavicular joint. Scapular anatomy, the scapula is funky to say the least. So lots of really important bony prominences. So we've got that inferior angle and body of the scapula. We've got the glenoid cavity, which is articulating with the humeral head. We've got that coracoid process, which is importantly the attachment site for the short head of the biceps, as well as the coracoclavicular ligaments. And then you've got the acromion, which is that superior roof of the glenohumeral joint, which causes lots of problems like subacromial impingement. If we flip that scapula over and look at the posterior aspect, we've got that large infraspinous fossa, which is where the infraspinatus is going to live, the supraspinous fossa, where the supraspinatus lives, and in between them, the scapular spine. Superiorly, we have that superior angle, but if we follow that along laterally, you've got that little suprascapular notch where the suprascapular nerve runs through, and you can suffer traction-related injuries. In terms of the neurovasculature around the scapula, again, you've got the suprascapular artery and nerve that are going to run right through that notch and make a 90-degree right turn and then move their way inferiorly. You also have the origin of the triceps inserting on the underside of the glenoid and the circumflex scapular artery running inferior to that. So majority of that blood supply wrapping around it is the suprascapular artery and then that circumflex scapular artery. When it comes to ligaments, there are lots of ligaments that help stabilize these joints. You've got the acromioclavicular ligament that we're all very familiar with from AC joint injuries. And then you have two coracoclavicular ligaments. So you've got a big, wide trapezoid ligament, more laterally connecting the coracoid process up to the clavicle, and then the more medial conoid ligament, attaching to that conoid tubercle on the clavicle. Medially, you've got that big, sturdy, thick, fibrous sternoclavicular joint, which actually is so big that it has a little intra or an articular disc between it. Think of like a meniscus or a TFCC, and lots of fibrous ligaments all wrapping around that sternoclavicular joint to make it stable. Also, just thinking about the musculature in the area, because the muscles which insert upon the clavicle are going to create displacing forces for it when it's fractured. And so we've got the big, long, thick strap muscles that make up the sternocleidomastoid that are going to be moving medially. We've got the trapezius inserting and the scalenes a little bit more laterally. And then you have the deltoid inserting on the more lateral aspect of the clavicle and acromion. So let's jump right into clavicle fractures. Clavicle fractures make up about 2 to 4% of all fractures, more common in males, 67% relative to females. And the mechanism is overwhelmingly a fall onto the shoulder, typically the anterior or lateral shoulder. About 7% coming from a direct blow to the clavicle and 6% from a fouche injury transmitted up the arm into that clavicle. And there's no real correlation between mechanism and fracture location, which is important. We classify these into type 1, 2, and 3. The middle third, which is the most common, are type 1s. The lateral third, which are second most common, are type 2s. And the medial third, which are third most common, are type 3s. It is really nice when the numbers match the percents. So the overwhelming majority of clavicle fractures are going to be mid-shaft clavicle fractures, 80%. In terms of presentation, they will have pain with arm movement. Typically, the arm is held to the chest to prevent any movement. They may have a visual prominence over the clavicle at the fracture site. They'll have focal tenderness to palpation, oftentimes with crepitus. They can have ecchymoses and skin tenting, and uncommonly pneumothorax, hemothorax, or neurovascular injury to the subclavian vessels and nerves running right there. In terms of imaging, you want to make sure you're getting two views, so an AP and then a 30-degree cephalic tilt. This is going to be your classic clavicle view. So for example, the image here on the right is that cephalic tilt, and you can see this central butterfly fragment really nicely that you would have missed on a straight AP view. You can consider stress views, especially with the distal clavicle fractures, if you want to evaluate the stability of those coracoclavicular and chromioclavicular ligaments. A Zenka view is a nice wide side-by-side comparison. And then a Kasana view is 45 degrees superiorly and inferiorly oblique views to the clavicle. So if you can't see everything you need with that 30-degree cephalic tilt, you can ask for the Kasana views. In terms of CT scans, these are really helpful when we want to clarify complex fracture patterns. So for example, we've got this very comminuted mid-shaft clavicle fracture that looks like also has an adjacent rib fracture and then a separated AC joint. This is complex, and so we really want to make sure we understand in 3 dimensions what's happening to the bones, especially given all the other important structures in the region. So those group 3 or type 3 fractures, those sternoclavicular ones, very important, lots of vital structures in the area. And then group 2 fractures, if you really can't clearly see what's going on, a CT scan can be really helpful. Okay, so
Dr. Goldman,
right into the...
Dr. Goldman.
Yep, really
so for those type 3s, just because you said that there are a lot of like important neurovascular structures there, if you're getting a CT, would you want to get any sort of like venography or like vessel imaging with that CT just to rule out any like vascular injury, or do you just get the plain CT?
Depends on what is displaced where. So if you have posterior displacement of fracture fragments back to the bad structures, then yes, you want to consider some kind of angiography. If the fracture fragments appear to be displaced anteriorly, less concerning. Okay, so Brian, since you are our in-house fellow, what is your diagnosis for this fracture?
So, I mean, it looks like a comminuted fracture. You've got that, I don't know, you call it kind of a central butterfly like component, but it's a middle third comminuted clavicular fracture with, I don't know, 2 centimeters of shortening. I don't know how that is. And apex, I guess that would be like, is that superior displacement?
Yeah, so you could just say superior displacement of the medial fragment.
Okay.
Yeah, so this is ugly, but also much better described by Brian's description. So mid-shaft clavicular fracture that is comminuted, shortened, and displaced with butterfly fragment is the term for that middle piece. So why are we seeing this movement of the clavicle when it's broken? So medially, you've got the sternocleidomastoid muscles, which are pulling the medial fragment superiorly. Laterally, you've got the weight of the arm, which is pulling the lateral fragment distally. And so that's why you're going to see that classic separation pattern with a mid-shaft clavicle fracture. So these group 1 or type 1 middle third fragments fractures are typically managed non-operatively. We'll put them in a sling for comfort, which is equally as efficacious as a figure of 8 for managing that discomfort. So when you see young kids come back to clinic and they can't wait to get out of that figure of 8 brace, these are really just being used for their comfort. They didn't need to be in them to begin with. So I typically will place the patient in a sling. Healing time for adults is between 6 and 12 weeks. For children is much quicker, typically 3 to 6 weeks, although I'll hold them until 8 for contact. And you want to follow them every 2 to 3, sometimes 4 weeks, depending on the displacement and shortening of the fracture. I will typically follow these out to that 8-week mark where I can document good resolution on radiographs and clear them for contact activities. There are some indications for operative management. Those are skin tenting or any open fractures. In adults, displacement greater than 1 bone width, we are now moving back towards the trend of plating these. Any significant amount of shortening, so I use 2 centimeters as a quick and dirty cutoff, but the textbook answer is 18 millimeters for males and 14 millimeters for females. And then what is called a floating shoulder. So any patient with a glenoid neck fracture concurrent with a midshaft clavicle fracture now no longer has articulation with the axial skeleton for your shoulder. So that needs to be managed surgically. When we talk about displacement, so why do we use these numbers? There was a study in '97 where they showed that less than 5 millimeters of shortening was totally fine. And another study in '97, research goes in waves, where greater than 2 centimeters of shortening, they were at higher risk for non-union and poor functional outcomes at 3 years. So this is, again, because this concept of 2 centimeters of shortening of the arm becomes clinically significant. So here's that 100% displacement and fairly significant shortening, but lots and lots of callus. So non-operative management, they looked at a simple sling versus figure of 8, just in case you didn't believe me, and they found less discomfort with the sling. Functional and cosmetic results were identical. And alignment of the healed fragments was unchanged from the initial displacement in both groups. So put your patients in a sling, tell them to get rid of it when they feel comfortable doing so. When it comes to operative management, just a little history of how we manage these. So originally we used something called Kirschner wires or K wires you might have heard of, where they would just place these down the axis of the clavicle. It's nice because you're not creating a surgical scar and having a prominent plate overlying the clavicle superiorly, which can cause skin irritation and complications when we're wearing a backpack or carrying a purse, for example. Problem is that 50% of these wires migrated. So if you are an astute radiography evaluator, you see that one of these K wires ended up in the neck of this patient, which is a big problem. So now we have moved to plate fixation. So you just see a simple plate placed over the fracture fragment with screw fixation. We can see complications with these, although rare. So clavicle shortening is one of the most common ones. Or one of the most common risk factors. Females tend to do less well than males. The comminuted, so those butterfly fragments and significant displacement don't do well. The greater velocity of initial trauma. So think motor vehicle accident versus a fall while running. And then older age, again, they've just got fewer stem cells left. Pneumothorax can occur. We see this in about 1 to 3% of all clavicle fractures, as well as neurovascular injury, again, to the subclavian structures. And then brachial plexopathy, this is actually caused by abundant callus formation. So you think of those newborn clavicle fractures during birth, they create so much callus that they'll often present with a quote tumor and loss of use of that upper extremity. So the callus can cause a plexopathy. All right, next up, let's go alphabetical. Di Stefano, what do you see?
All right. We've got a distal third clavicle fracture that I can say is non-comminuted, is a medial apex is displaced superiorly.
Excellent. Yep, that is perfect. So distal third clavicle fracture with, let's say, 75% displacement of the medial fragment superiorly. So let's talk about these group 2 distal clavicle fractures. Remember, the second most common type we will see. In Neer, the same guy who gave us the Neer test, has a classification system for these. So a type 1 occurs distal to the coracoclavicular ligament. So these ligaments are intact. A type 2 is medial to the ligaments with ligaments remaining intact. Now there's a 2A and a 2B. So a 2A is no ligament tears. A 2B is lateral to the conoid ligament, and both ligaments are torn. So here's your 2B. Sorry, it should be single ligament torn. And then a type 3 is intra-articular through the AC joint, which is rarely displaced because the AC joint capsule is going to hold it in place. A type 4 is a physeal fracture. So here's the physis, and the clavicle displaces superiorly through torn periosteum. This is complicated to manage. And then a type 5, these ligaments remain intact, but you have 3 fracture fragments, 1 attached to the ligaments, 2 laterally, and 3 medially, which is inherently unstable. So as we're dealing with all fracture management, you need to ask yourself, is this stable or unstable? Unstable fractures need operative management. Stable fractures can be managed non-operatively. So that type 1 is stable with the ligaments intact, stabilizing the distal clavicle. So these can be managed non-operatively with 6-week healing time. The type 2s are unstable because there is nothing that is maintaining the position of the distal clavicle. So these need to be managed operatively. The type 3s, going back to give you a visual, are stable, small intra-articular fracture. So you can manage it non-operatively. The type 4s are stable, although albeit ugly, but can be reduced. The type 5s, unstable and need to be fixed. So again, you can memorize the table, or you can just think through this logically, which is stable, unstable. So again, complications are much more common in group 2s. These are more complicated fractures. You can be seen up to 56% with type 2s. I would argue those are probably ones that should have been managed surgically that they tried to non-op. We see a similar rate of pneumothorax and neurovascular injury here. And with the type 3s, remember this is an intra-articular fracture. Now we worry about premature osteoarthritis.
Dr. Goldman, quick question. So just in terms of stable versus non-stable, like one slide earlier. So I know you said type 4, obviously it's a physeal fracture. Looks very similar to like a type 2A, just in that I guess the fracture site is at the physes or physis instead of not the physis. How is type 4 stable and type 2A is not stable?
So type 4 is a periosteal sleeve fracture.
Oh, periosteal sleeve, okay.
Yeah, so that bone is sliding up through the periosteal sleeve.
Gotcha, but the sleeve is still...
The sleeve is intact. So if you can reduce the type 4, and now remember this is specific to pediatric population, reduce that back into the sleeve, this will heal fine.
Okay, that makes sense.
But it looks just like a type 2, to your point, except the physis is open.
Makes sense.
So you have to look for that physis to decide, is this a 2 or a 4?
Cool.
Okay. Last up, Dr. Oberly.
All right. So what I'm seeing is a medial clavicle fracture. I'm going to zoom in a little bit on my phone. It looks like it's transverse and non-displaced, at least in this view, with no angulation and likely no shortening, but I would probably want to see another view to see where that, if it's going in another direction.
Excellent point. So in a single view, no orthogonal planes, it's hard to tell if that's displaced posteriorly, anteriorly, et cetera, right? But in the single view, to our best bet, we know it's fractured medially and questionable displacement. So these group 3s, the proximal clavicle fractures, come in 3 categories: non-displaced, anteriorly displaced, and posteriorly displaced. We talk about displacement, it's going to be the lateral fragment. Remember that medial fragment is fixed to the sternoclavicular joint. So non-displaced are uncommon. So in general, group 3s are uncommon, but when they occur, they are frequently non-displaced. They rarely involve that really thick fibrous sternoclavicular joint. And so we can treat these really symptomatically: sling for comfort, early range of motion. We want to try and immobilize for a little amount of time as possible, just because we don't want them to get stiff, and just have a structured rehabilitation program. We are cautious about return to sport, obviously, because we don't want the non-displaced fracture to become displaced, but early range is encouraged. When it comes to displaced, now we're worried about mediastinal structures, right? So these need to be reduced. Open versus closed depends on which way things are displaced. And then surgical fixation, typically with a wire or a plate, or intraosseous sutures. So there's this really slick thing called a Balser plate. But if it is displaced, most important for you guys to know, this needs to go to the OR, and it needs to be reduced and fixed. Okay, you guys feel good on the clavicle? Take that as a yes. Scapular fractures. Okay, so these tend to be high velocity injuries. About 50% are coming from motor vehicle accidents. Associated injuries are high, so up to 80 to 90% of patients will have something else. So pulmonary injuries and 23%, clavicle fractures and 23%, which gives you that floating shoulder. Spine fractures in about a third of them. Shoulder dislocation, brachial plexus, arterial artery injuries, rib fractures in about half of cases. So high velocity, big trauma. Typically the high velocity is direct trauma will cause body and spine fractures. So this is now being tackled in the NFL, but previously, falling off a building on your back, falling in a half pipe, snowboarding, etc. The Fuchs type injuries will typically be transmitted to the glenoid neck. Fall on the lateral shoulder will cause an intra-articular glenoid fracture. Downward blow to the shoulder will fracture the acromion, and an anterior blow can fracture the coracoid. Imaging, you want to get your AP, axillary, scapular lateral, that's that scapular Y, and then a cephalic tilt. I included this image because you can see here on your scapular Y, you can see this subtle lucency through the body of the clavicle. And then you want to use a CT scan anytime you're evaluating glenoid fractures. These are incredibly complex, and again, millimeters of step off can make a big difference in terms of healing and shoulder function. I included this image because classification systems are complex, to say the least. For scapular fractures, there are 3 different classification systems. For glenoid fractures, there are 3 different classification systems. So it really is complex. So I'm going to distill it down into a much simpler version for you guys. Okay, so when we look at scapular body and spine fractures, these are going to make up the overwhelming majority of scapular fractures, 50 to 80%. The body and spine are relatively stable fractures because of the large amounts of musculature overlying and stabilizing them. So they typically heal well, 4 to 6 weeks, sling for comfort, supportive care, gentle range of motion, PT to regain strength. But these are very well tolerated. Scapular neck fractures become much more complicated. So these are about 10 to 15% of scapular fractures. We think of them in 3 subtypes. A type 1 is non-angulated, non-displaced, spectacular. Type 2A is shortened or displaced, greater than 1 centimeter, and a type 2B is angulated, greater than 40 degrees. So the A's are the shortenings, the B's are the angulations. In general, they want to angulate inferiorly because of the weight of the shoulder. Management for non-displaced is non-operative, no functional limitations. For displaced, it's non-operative, is going to cause significant functional disability. So if you are non-op managing a displaced fracture, it is someone who is absolutely not a surgical candidate. So our indications for surgery, if you couldn't infer from the subtypes, are greater than 1 centimeter of medial displacement, greater than 40 degrees of angulation, and a concurrent midshaft clavicle fracture, which makes you unstable. Okay, let's get into the glenoid, but very briefly. Glenoid fractures are about 10% of all scapular fractures, so relatively rare. About 10% of them are displaced, and the classification system, like everything else in the scapula, is complicated. A type 1A is the most common glenoid fracture. Does anybody know what a type 1A is called? I'll give you a hint, it goes with the shoulder dislocation.
Bankert.
Exactly, this is called a bony Bankart. So anterior glenoid rim fracture, AKA bony Bankart, is the most common type we're gonna see, which occurs with an anterior shoulder dislocation. So some general rules from this more complicated classification system from Eidberg is that closed reduction is unsuccessful in improving position of fracture fragments. So if you have a bony Bankart and you reduce the shoulder, or you have a displaced fragment and you try and reduce it without operative management, it's not going to work. Secondary improvement of the fracture fragment position is possible with conservative care from moldings by the muscles, but again, this should probably be managed operatively. A good result occurred in 75% of cases after early mobilization. So when it comes to the glenoid, movement of the humeral head in the glenoid is really important for articular remodeling. So those, surgically we try and get the glenoid as perfectly aligned as possible, but it's not always possible to make it perfect. And so early mobilization of the shoulder actually allows the articular surface to remodel as it heals. And ORIF may also provide good results in the absence of other significant shoulder fractures, nerve, or muscle injuries. So simple fracture without other stuff, they do well surgically. Surgical indication for glenoid fractures is involvement of greater than 25% of the glenoid with humeral subluxation. So when we get into hand fractures, say mallet finger, for example, that 25% seems to be the magic number of the articular surface involved for stability of the joint. So you have more than 25% of the glenoid involved, you're going to start to see subluxation of the humeral head. The other cutoff is greater than 5 millimeters of glenoid articular surface step off. So remember I said in general, as we're thinking about fractures, we don't want to tolerate articular step off. The glenoid can tolerate less than 5 millimeters. The last is excessive medialization of the glenoid. So if the glenoid fracture causes the whole glenoid structure to move medially, that's going to be problematic. Okay, next to acromion fractures, these are even less common, 8 to 9% of scapular fractures. Remember the acromion is the attachment site of the deltoid and is the roof of your glenohumeral joint. These also have 3 classification subtypes: a non-displaced, a displaced without reduction of the subacromial space, and a displaced with reduction of the subacromial space, okay? For non-displaced and displaced without collapse of the subacromial space, you can manage these non-operatively. So again, lots of musculature in the area that helps stabilize it. Sling immobilization for 3 to 4 weeks, PT for early range of motion. For a displaced type 3, where you have lost some of your subacromial space, this is this picture down here on the bottom, those need to go to the operating room for surgery. And next we have our coracoid fractures. So that little bony prominence in the anterior shoulder, which is the attachment site of the short head of the biceps, pec minor, and the coracobrachialis. An AC dislocation will concurrently occur in 90% of cases. So if you see a coracoid fracture, go looking at the AC joint. Type 1s occur proximal to the coracoclavicular ligament. So this is down here at the base. And a type 2 occurs distal to the coracoclavicular ligaments. I want you to remember one more global concept as we're subtyping these. Think the acromion and the coracoid. The subtypes are really trying to help you predict outcome, right? So that type 3 with the collapse of the subacromial space is problematic because it affects the outcome. Here, your type 1s and 2s, a type 2 distal to those coracoclaviculants is going to be much less problematic than one proximal to it. So management here is really controversial. Non-operatively, we'll do a sling for comfort and symptomatic treatment. But surgical indications include prevention of glenohumeral relocation, i.e. if a fracture fragment occurs with a glenohumeral joint dislocation and you can't reduce the glenohumeral joint because your coracoid fracture fragment is in the way. Second is a painful non-union. So this is more common with the base, these type 1s, where all of the forces short of the biceps, pec minor, as well as the coracoclavicular ligaments create a lot of stress and can cause pain. And then, quote, significant displacement. This is highly variable in terms of what significant is in the literature. We love to use 2 centimeters for everything because it makes life simple. But really, these are uncommon, not well studied, and so we haven't really identified what that significant number is. So let's review our clavicle fractures. Middle third are the most common, and we want to manage these conservatively unless we have 15 to 20 millimeters of shortening and greater than 100% displacement in an adult. Return to play, specifically return to contact, is about 8 to 10 weeks. A distal third are the most complex. They have all those subtypes. And you really want to ask yourself, is this a stable fracture? Because you're going to have a 50% non-union rate with the unstable subtype. And if it's unstable, it needs to go to surgery. The medial thirds are extremely, extremely rare. If it is non-displaced, it is stable, leave it alone. If it is displaced, it needs surgery, and that needs to happen urgently because of compromise of adjacent neurovascular structures. When it comes to scapular fractures, body and spine are most common, almost always non-operative because of all the stabilizing musculature around them. Symptomatic management in a sling. Next most common, 10 to 15%, and anatomy is key. If you are displaced, shortened, or angulated, you need surgical intervention. The glenoid is 10%. Again, depending on the fracture pattern, you want to consider the CT to evaluate better. Shoulder stability is key. And remember, 25% of the glenoid surface is that magic number. If there is displacement greater than 5 millimeters of the articular surface, which you need a CT scan to calculate, or instability of the humeral head, which is greater than 25% of that glenoid surface, then it needs a surgery. The acromion, even less common. The majority are non-displaced, but if displacement is causing collapse of that subacromial space, those type 3s, you want to operate on them. And then the coracoid often comes with AC or glenohumeral joint dislocations. We typically try to manage them non-operatively unless they're symptomatic. And with that, let's open it up for questions.